I would like now to invite a panel of providers for a roundtable discussion. Our panel includes Melissa Taussig, who's in private practice, Dr. Thiran Jayasundera, who's the Paul R. Lichter Professor of Ophthalmology at the University of Michigan, Rochelle Neutra, who is a patient, provider, advocate, and Prevent Blindness Aspect Program graduate, and Dr. Kelly Scherer, who is the Director of Clinical Services at the Lighthouse Chicago. So to start off the discussion, I would just like each of you to introduce yourself briefly and share a little bit about what you do. Maybe we could have Melissa, you go first.
Hi, I'm Melissa Tossig, and I'm a licensed clinical mental health counselor in the state of Illinois. For my audio description, I have long blonde hair, brown eyes, and I'm in my early 40s. I provide my services mainly over telehealth. I started out working in the field of low vision rehabilitation, and so I continue to collaborate with providers and interdisciplinary teams to provide consultation. And then I offer adjustment support counseling to those who are impacted by vision loss, as well as their families and support systems. And my areas of research include stigma and uncertainty as it relates to vision loss. And thank you for having me.
Sure, thank you for being here. Thiran, can you introduce yourself?
Hi, everyone. I'm Thiran Jayasundera. I'm a retina specialist seeing patients at University of Michigan. I specialize in inherited retinal diseases. I have a research program that assesses patient functioning and patient anxiety, and I have federal funding to sort of have unique interventions for these disabilities and anxiety. My audio description is that I have receding black hair, and I have brown skin, and I'm wearing glasses.
Yeah, thank you. Kelly?
Hi, everybody. My name is Kelly Shearer. My audio description is I am a white female in her 30s. I have long brown straight hair and brown eyes, and I'm sitting in my optometric exam room today. I am the Director of Clinical Services at the Chicago Lighthouse, and I am a optometrist that practices low vision rehab. I work on a team of interdisciplinary professionals here at the Lighthouse. And our agency is a large social service agency for the blind, visually impaired, disabled, and veteran populations. We have over 40 programs that help to support these populations, and clinical care is one of those programs. So I'll talk a little bit more about what that entails as we kind of move through this.
Okay, thank you. And Rochelle?
Hi, my name is Rochelle Neutra, and I am brown skin. I'm wearing a brown hat, brown glasses, and a blue plaid shirt. And I'm trained as a family nurse practitioner. And for the past several years, I've been serving on nonprofit boards and advisory committees with a current focus on health, design, and housing. I'm also living with recurring corneal erosions, which means that the cells on the outer part of my eye become loose, they raise up, and they break apart, which causes me to have ongoing migraines and eye pain. And I'm also extremely sensitive to light. And these conditions brought me to Prevent Blindness last year. I participated in Aspect, and I also serve on their advisory committee for the Center for Vision and Population Health.
Okay, thank you. So what I'm going to do now is ask questions, sometimes to specific members of the panel, and sometimes for the whole panel, for anybody to answer in any order. But I'd like to start off with asking you, Rochelle, a question. Actually, three questions, that are all related, but I'll ask them one at a time. So you bring a unique perspective to your work, I think, as a nurse practitioner and as someone who's experienced an eye injury. What would you say are the important questions you are asked or not asked about your mental health when you began to receive vision care?
Well, I wasn't screened or assessed. I think 8 years into my treatment, I was given a written depression screening form, but I was unable to read it that day. So I didn't complete the form and there was no follow-up.
Okay, well, that short answer says a lot. 8 years, wow. That we need to improve that situation.
Yeah.
So other than that, are there any other gaps in healthcare delivery that you'd like to mention that you've experienced or heard about?
Sure. I mean, this is just my personal experience. And just to set the stage, I had an eye injury, and within months, I had to stop working. I had to spend majority of the day in a dark room. And my condition was disabling and difficult to treat. And luckily, I had access to care, and I had many motivated providers that were seeing me, but I wasn't necessarily receiving the right care at the right time. I wasn't offered access to social workers or mental health services, occupational therapy or rehab, and I really wanted to, get back to work. My pain was not adequately assessed or treated, and I think it took around 7 years to receive the specialty contact lenses I needed to help protect my cornea. And throughout my treatment, I was using all of my skills as a clinician and researcher and advocate to sort of push along my care. And, I was capable of doing these roles, but in this case, I was the patient, and I was exhausted, and it was stressful to feel like I had such a big responsibility in my care. And in retrospect, I think having a case conference, a meeting with me and key members of my medical team, even if it was just with the corneal specialist and my primary care, this would have been helpful because it could have maximized our efforts and identified what was falling through the cracks, and we could have made a plan to address those gaps.
Yeah, okay. Yeah, well, that really speaks to the integration of services that the task force that Julie just discussed gets at. Really important. Now, the third question I had for you is, what would you say you think are the most important things for primary care vision providers to know about eye health and mental health?
I would just say that, depression and anxiety happens. So regardless of how a patient presents, ask about mental health.
Yes, that's very good advice. Thank you. Okay, I'd like to ask a question. So just to review, you practice at the Chicago Lighthouse as a low vision rehabilitation specialist and optometrist. But I think there's probably a lot of people on this meeting today who aren't familiar with vision rehabilitation and what it is. So can you describe what it is, what services are included, and how, if mental health issues are addressed as part of the rehabilitation work that you do?
Absolutely. So lots of people come into my chair, and even after arriving and booking the appointment, don't know what we do. A lot of people get referred by their ophthalmologist or a friend to us, and are kind of anxious on the approach of seeing somebody who works with the blind. As a low vision optometrist, we really welcome anybody who's experiencing any level of vision impairment. Vision impairment is a spectrum, and it can impact your life at any stage. Part of our assessment is we really begin with a functional history. We want to understand the patient's lifestyle, how their vision has impacted their lifestyle, what their limitations are, and what their personal goals are. Everybody's different in what they want to accomplish, and vision plays a role in that. Then our exam is also very functionally focused. So different to a eye exam that you would get in a general ophthalmology or optometry practice, we're looking more at what's the level of vision impairment, and then how is that impacting your function. So how is the disease impacting like what you're trying to get done? So we're looking at like reading speeds, we're looking at mobility, we're looking at like ability to utilize a computer, a phone, kind of these daily skills. Then we're working on like goal-based solutions. So we're using devices and resources and kind of adaptive strategies to help people overcome like the challenges they're experiencing. We have a interdisciplinary team that we work with. So typically the patient comes through and meets with a optometrist first, so that we can assess the level of visual impairment and what would be the most appropriate devices for them. Then they typically will work with an occupational therapist who provides more compensatory strategy training and hands-on adaptations. Then we also have mental health care providers on our team who can provide emotional support, counseling, support groups. We have more social engagement models for seniors and youth to connect with community. And then we also offer mobility training to help with independence and navigation, and assistive technology to help people with utilizing their technology, and employment services. So we help people with regaining employment and skills needed for employment. So we try to take patients from the point of diagnosis to regaining function in whatever areas are important to them and whatever areas they feel like they need to prioritize. It's really individualized approach. We spend a lot of time educating the patients on what's available to them and kind of catering to their needs.
Okay, thank you. Yeah, that's very important work, and it sounds really optimal that you're part of that team with other professionals so that really the whole person can be taken care of. It's not just the vision, problem necessarily just by itself. Okay, so my next question is for Melissa. As we just heard from Julie a few minutes ago, one of the key takeaways from the Prevent Blindness Mental Health Task Force is that there's a difference in coping or psychosocial adjustment for people who, let's say, are born without vision or develop it very early in life versus people who are having vision loss gradually over time, or people who may lose it suddenly because of an eye injury. Can you talk about, as a provider, how can providers adapt their care and mental health support based on how and when vision was lost?
Mm-hmm. Yeah, and I think Prevent Blindness has done just a beautiful job of highlighting these differences. It's a question that comes up often, even with my practice, from clients themselves. How is it different, or which one is better or worse if you're born with vision loss or if you acquire it later? And I didn't mention earlier that I was born with a congenital eye condition called optic nerve hypoplasia with nystagmus. So I have that shared experience as I connect with my clients. I also have vision loss. And I think, again, there are many shared experiences. We all navigate similar social barriers and similar access barriers. However, as Julie mentioned, when you acquire vision loss later in life, it is a huge shift in identity, and it also can directly impact the level of independence that a person has. The examples shared throughout the presentation so far have really reiterated that. And so I think it's important to note that. And also the role that trauma can play in a diagnosis. I've worked with, many clients over the years who have literally woken up and lost their vision, and they had no time to prepare. It was sudden onset. And so as a provider, just having the sensitivity that people, and honoring the fact that people are at all different places on their journeys of processing and adjusting. And there's no right or wrong way to navigate through vision loss. There's a saying, when you've met one blind person, you've met one blind person. So just acknowledging that personality, environment, support system, culture, all of those factors are going to play into it. And just, being able to come alongside the patient and just say, you are not alone. Anyone in this situation would have a similar reaction to this diagnosis. because many people feel as though they're not doing it well. A comment I hear a lot is, I'm just not good at vision loss. And that's not the case. Anyone in that situation would be facing similar challenges.
Okay, thank you. Now I have a follow-up question for you. You sometimes use the term or acronym STUG, S-T-U-G. I think most people won't be familiar with that. Can you tell us what that stands for, what it means, and why it's important?
Sure. A STUG stands for a sudden temporary upsurge of grief. And it was coined by a clinical psychologist named Teresa Rando, and really just acknowledging the fact that grief is a part of, I think, most people's journey, whether you have congenital vision loss or acquired vision loss or traumatic vision loss. But a STUG is just a really helpful term to put language to that type of grief that might even show up in an exam room, where the patient could become tearful and overwhelmed. An eye exam is a big stressor. That's another thing, that my clients will process with me as they have an appointment coming up. And Julie mentioned anticipatory grief. They don't know, is their eye condition has it remained stable? Has it changed, and what does that mean for all of the other layers of life? And so just being able to put words to that, even with a patient saying, oh, that there's actually a name for what you might be experiencing right now. It's called a STUG. It means that this grief can just suddenly well up. It could be anywhere, but it's temporary. And it's will go away, before too long. But just to validate that, maybe the person is at the grocery store and all of a sudden they realize that they can't read labels on the cans, or they can't figure out what money they need, read the denominations of money as they're trying to check out, and this grief can kind of grab hold. So it's just a really helpful way to understand that, again, you're not alone. This is a very common experience that you can be in a public or, a public setting or the privacy of your own home, and you may feel this upsurge of grief, but that grief ebbs and flows. It's totally normal. And those tears can actually be very cleansing. And it's not something that we have to avoid. It's just something that we can know will happen from time to time.
Okay, thank you. Okay, Sandra, you recently published an article on the relationship between vision-related anxiety and disability. Can you tell us more about that study and what the main take-home messages were from that?
Yeah, when we have a vision disorder, we have certain disabilities that are vision-related. This may be walking outside, bumping into people, etc. Or maybe, reading, it may be recognizing labels. Then we also have anxiety that is vision-related. In broad strokes, in terms of the retina, we're talking about the night vision, the rod cell-derived forms of functional vision, and the cone cell forms of functional vision, which are sort of your central vision and your contrast and color vision. So we were able to look at these forms of anxiety and these forms of disability. And we also looked at people's actual vision measurement that they would have when they, visited a provider. And what was very strongly correlated was that your disability and your anxiety just run together, even when controlling for the vision measurement. So two people could be of the same vision measurement, like 20/40, 20/60, but one person who has more disabilities that are vision-related will have more vision-related anxieties. So that was an important association for us to make, because the question often is, does the anxiety that you have contribute to your vision-related disabilities? So we've, did a subsequent paper on that topic. There's a criteria called the Hill criteria, which sort of, can sort of help us guide whether something is causal. And so you look at these different factors and you say, well, looks like the anxiety causes you to have more disabilities. And when we looked at those Hill criteria, there's a lot of support that the more anxious you are, the more disabled you'd feel. So I think the takeaway point is that, when you go to visit someone like Kelly or Melissa, you want to, optimize that rehabilitation that you get from low vision. And if you're really well prepped for it, from a psychosocial sense, then I think you probably would do better with your low vision rehabilitation.
Okay, thank you. Yeah, that last point I think is really important. That the synergy, that if people are dealing with mental health issues like anxiety, they can benefit more from vision rehab services. So thank you for that answer. My next question is for Dr. Shearer again. Can you share a story or two from your own work about the potential impact of vision rehabilitation on mental health and wellness?
Absolutely. I could do a whole panel on stories. I have two that I'll share, and dock me if I'm on time. I have one patient that I have been working with, who, when I first saw her, she was really struggling mentally. She had lost two of her children to gun violence in that year, and she was also progressively losing her vision. And not only was she experiencing like the grief of losing her children, she also had lost her support system and the people that were helping her with tasks that she couldn't do because of her vision. So she kind of came to me saying, I'm like not managing my household. I really can't take care of things. I'm like struggling, just kind of stay above water. And so as part of our assessment, we kind of talked through all the resources we have available. And so I got her connected with our psychologist and our occupational therapist, and she was open and accepting of the services. And so I kind of got her started with those things. I saw her more recently. It had been about like a year since I had first evaluated her, and she had just totally flipped the script on what she said to me the first time. She, as I kind of was working through my history with her, was like telling me how much confidence she had gained in cooking and navigating and taking care of like her day-to-day tasks. She was explaining to me like how much like the direct care of like the OT had helped her with like learning all these functional adaptations that she's been able to apply, and how much like working with the psychologist has helped her to gain coping strategies and like better manage her mental health. Not that the vision's getting better, but that she has kind of like this arsenal of like tools available to her to work through it. And so that was like an amazing just experience to see how much independence she had gained through the vision rehab, and how that had impacted her mental health as well. I have this other patient that I have been working with for a few years who, when I first met her, she had been diagnosed with a very rare condition that she had been going to doctors all over the country to get an answer for. And when she finally got the answer, they told her, very rare, you're going to progressively lose your vision. And so she had a lot of anxiety about what this could become and what it currently was. And she had worked in tech her whole career, and she had this like attitude of like problem solving, like I'm gonna figure out the solution, I can do it. Like she was like so motivated to work through it. And so as I met with her, we got her connected to all the services, and she really like just dove headfirst into it. She worked with like me on every device possible. We worked on like distance magnification, near magnification, optical tools, electronic tools, like compensatory strategies, like tints, glasses. She was like open to trying everything, and it just made her rehab really fruitful. Not that everything like was perfect or the right tool, but she was like open to exploring what was available to her. And then she worked extensively with like our technology team, our occupational therapy, and our psychology team. And now, like 3 years later, her vision is worse, but she's like doing so much better. She like same thing. She just like has the like tools and like the skills, and she has the resources and the support system that she has developed and like put this work into to get to where she is. And now she is working with a national organization as a mentor for people who are newly diagnosed with vision loss. And so I try to give that as an example to some of my clients of like, you can utilize this experience in a really positive way. And like, there are good things that can come out of this.
Yeah, thank you. Those are really nice stories. And I think one of the key messages there, I think, is it's important to have access to a team like that. So the people going to where you are, the Lighthouse in Chicago, are certainly fortunate because that kind of team is there. So I'd like to ask a question now for anyone on the panel to answer, or more than one person to chime in on, which is, we just heard an example now, and we heard from Julie before about an integrated eye care model. And clearly that seems to be very effective and the way to go. So this is a model that would include patient navigators, peer support teams, mental health professionals such as social workers and psychologists, psychiatrists, eye care professionals, and other healthcare professionals. So these people exist pretty much everywhere. But the question is how to form a team and how to get everyone to work together. How does that happen? How do we get from where we are now, which is most places, most people don't have access to the kind of integrated services that we just hear about at the Lighthouse. So how do those types of services form at other places?
So I can speak to that because, I've worked mostly in community health centers and primary care settings. And so we did a lot of what we call team-based care. And so I think one thing to think about is that anybody that touches the patient, has any contact with them, that could be the front desk, it could be the medical assistant, whoever's rooming the patient. I'd remember that all of those people comprise your team, including the other people that we've already named. And in order to improve the care that the patient is receiving, I think we have to be functioning well. We have to have good communication. We have to understand each other's roles, because we want to make sure that if we're referring our patient to another provider, that, the referrals are intentional. And then both that the provider and the patient knows what to expect, because it takes a lot of energy for folks to, meet a new team member. Energy to get to the appointment. They may, sometimes there's expectations because they're really excited because they feel like, this is another chance to, to improve my care. And so we really want to make sure that we're using those referrals well. And I think we need to make sure that we value each other's roles, right? Because if we want to sell your team members to your patients, you need to believe in them also. And lastly, I was going to say, like, as long as it's appropriate, if we're making referrals, we want to ensure that when the patient arrives to the next person, as long as it's appropriate, we don't want that patient to start from zero, or that provider should have enough information so that patient feels known to that provider, so they don't have to repeat every part of their history again. And again, we know that we're always going to ask individual questions that are appropriate to our treatment plan, but we want them to like land with them and feel like they're part of a team.
Okay, thank you. Any of the other panelists want to add to that?
Yeah, I can add to it a little bit. So I think for many different disciplines to work together, we all need to understand what each discipline does. And we also need to have some kind of tool to measure, for example, a disability or anxiety that would mean that that patient requires to be referred to that other discipline. And then also that discipline, so say take mental health professionals, need to have that expertise in dealing with patients with vision impairment and blindness, because it sometimes isn't very productive if they don't have that expertise. So, so say you have all those things aligned, and you can form this sort of multidisciplinary team, and everyone is willing to refer to each other because they feel supported, and there are sort of tools that can help you guide who to refer to. Then you also need a funding sort of system that will fund for certain services that are not typically paid by health insurance. So I think, Kelly, you may be able to talk about this with the Chicago Lighthouse. I'm guessing that a lot of the services provided are through philanthropy. Is that correct?
Yes, yeah, we have quite a bit of grant funding for non-reimbursable services. So things like orientation and mobility are non-reimbursable, assistive technology. So a lot of these support services that are patient-centric, but are not recognized as healthcare services. I'll just kind of take it from here, if you don't mind, and make a quick additional comment. I would encourage providers to think of this more as like building a network and not like you're building an entire center. Like it's quite daunting to think like I need to create an interdisciplinary team and like create this like new healthcare model. But like it can be as simple as, finding a mental health care provider in your community that's willing to have open communication with you and sit down and have a lunch and talk about how your patient's vision loss is impacting their mental health. I think that's a great starting point. I totally agree with Rochelle. The more communicative we can be between disciplines, the better for the patient. But it's not always going to happen, especially in U.S. healthcare in the same building. And so, to the best extent that we can support the patients in creating the referrals and providing the communication, we can do that kind of across disciplines and across locations.
Okay, thank you. And for my next question, this is for the two eye care professionals here, Ron and Kelly. What would you say are some of the common barriers that you see in patients that get in the way of them addressing their mental health concerns?
I can start. So Julie, I think, gave a nice summary of what the task force found in terms of barriers. And, I think just to reiterate some of the things, I think providers don't typically ask about mental health, and that could be for a number of reasons, including time constraints that they have in their practice, and the second is that we don't often have tools at our fingertips to use to measure it and to understand the scores that you get from them and what to do with those scores. The third is that we don't have someone to refer to that can be of help to your patient. We've heard of numerous examples of therapists that sometimes don't understand blindness or vision impairment, and having not being as useful in when referrals are made. So I think that's really the fourth thing, that we need to train our mental health professionals to be aware of issues surrounding vision impairment and blindness.
Okay, yes, those are all very important. Just shows you how complicated, again, the situation is. Kelly, did you want to add anything to that?
Yeah, I think I had similar points, but I think one of the biggest concerns we have, and the reason we're having this conversation is, a lot of providers don't even ask. Like, let's start with the simplest thing, asking your patient how they're doing, and go from there. I think it is, in medicine, we think so heavily about working in evidence-based models, screening evidence-based models, but the studies show that that as providers, we significantly underestimate how disabling vision loss is to patients. So realistically, I think, an open-ended question to a patient is effective. The patient says, I'm not doing great, they're not doing great. And if they say I need support, they need support. I think we can start simple.
Okay. And now I'll just ask this for the whole panel, but so let's say that either through screening or someone just comes out and says, I really could use some support for, emotional distress or something. What kind of interventions are available? What do you refer people to receive?
I'll start. I work in private practice, and so many of my clients are referred by providers, either low vision optometrists or rehab teachers or organizations. And I'm always grateful every time I get a referral, just, knowing that client was told that mental health support was out there, because ideally it would be great if every low vision rehabilitation setting offered adjustment counseling, and that's not the case right now. So as Kelly was saying, having that network is so important. So also, as part of my work, I also do group work with an organization called Daring Sisters, which provides a community for women who are dealing with vision loss. And we provide 6-week, either in-person or virtual retreats. So in addition to getting that individual adjustment counseling, we have kind of created a way for women to be able to find community and share their stories with other women. And in the midst of the weekly community experience, we also provide coping tools. So we talk about navigating grief, we talk about stigma, we talk about uncertainty. So those group resources are available. And then also, I think it's important to highlight the importance of including family. The grief surrounding vision loss doesn't just impact the individual, it affects the family. For example, if a woman has RP and she's a mom, she may have to stop driving and she may not be able to be part of a carpool anymore. And her kids are dealing with the loss of not having their mom for that experience. Or her husband is maybe needing to take over some of the carpooling. So also just really including the family and making sure those resources are available to the whole entire support system, not just the individual.
Okay, thank you, Melissa. Other panelists want to add to that about the kind of interventions that would be helpful to people looking to get some support around mental health?
One other thing that I encourage my patients to get involved with is some sort of community aspect or social engagement. So sometimes like one-on-one talk therapy can be really intimidating to people. Support groups seeking mental health can be really intimidating, like services can be intimidating. But if I ask them if they like would like to go do like a social activity with a group of people who are blind, it's like sometimes a little bit more approachable. So depending on the client, there certainly are lots of different social programs through agencies for the visually impaired kind of across the country. But sometimes that's kind of a gateway to help people cope and like develop community.
Okay, thank you. Now we have time, I think, maybe for one more question. So one question I think is important to ask here that we haven't really talked about is what's the role of the family and other people in the lives of people dealing with vision loss and helping people to maintain an optimal state of mental health? Go ahead,
So,
Rochelle.
sure, I can jump in with that one. And again, just with my eye condition, it affects my vision because I am sometimes unable to correct my vision because it's hard to wear glasses. I'm also not able to be exposed to light. And so without light, it's hard to see. And it's hard to engage with the built environment because it's lit. And so I had to change a lot of my activities. And I would say for my family, it's like, and friends, like being supportive meant that they're flexible and they're adapted to the changes that I was going through. It was important that they were encouraging, but also knowing sort of like when to listen, when to be quiet, because you need to give the affected person the space to direct how and when support is given to them. They may have lost certain abilities or had to relearn how to do activities, but it doesn't mean that they necessarily want you to take over for them or treat them like they don't have agency. And I think it's important to also to offer support, but don't be offended if your loved one needs to figure it out on their own or even like make their own mistakes, with something that you think that they shouldn't be doing. Because, from a practical standpoint, my family and friends and community were my safety net. My husband became the sole breadwinner, and this was just like 6 months into us being married. And, he took over most of the household responsibility. And, it sort of was my rock. I mean, and this gave me stability because I had housing, I had food, and I had health insurance, through him. Practical support from people were giving me rides. They were, I had friends that would come and hang out with me in waiting rooms. And it's not because I needed someone to help me with my medical appointments, but it's because I felt like I was practically living at my clinic in my hospital. And so I almost like would make it like a date. They'd come hang out with me and then we get coffee afterwards. Or, I even had like a friend, I had surgery. So I'm sitting in my bed in the dark with a hat on and dark glasses. And I also used to play music. So I had my instrument next to me. I don't know why. It was almost like my safety net, And, a girlfriend would just came and sat with me on my bed and made that normal, right? Because that was my new norm. And lastly, I would have people like my husband he was working out of town for the first 3 months of my condition. And it was really important for me that he do that, even if it wasn't totally practical. But I was lucky because I had friends that could come and stay with me when I was having sort of these medical emergencies. Friends that volunteered to take me to the hospital and friends that would come stay overnight after I had surgeries. So.
Okay, so thank you. Now we have about 30 seconds left, so I just want to throw out a follow-up question because you're describing some very important support, and in some cases you taught the people what you needed. and how to be most helpful. But many people won't know, family members won't really know. And what they think might be helpful is actually not helpful because it's infantilizing or, is not helpful in some way. So are there any existing resources for family members or loved ones that people can, let's say your husband could have gone to learn about how to support living with someone with vision loss? Are there groups, resources out there already?
I'm going to pass that to the group because I actually haven't had access to those type of resources.
Yeah, I don't know if they exist. That's why I'm asking the question. It seems like it would be very important to develop such things if they don't exist.
I'll jump in. I know Prevent Blindness has worked hard to get up the website Living Well with Low Vision. And on that website, there are some resources to educate family members. And I think that's the key, the education piece, and that can start maybe at the ophthalmologist's office or in the low vision rehab setting. I know I've recommended to clients asking if it's possible to have a vision simulation if they're at, seeing their low vision optometrist and they have a particular eye condition, let their spouse put on a pair of glasses and have the low vision optometrist try to simulate what their vision is like. Because a common concern that comes up is a husband or wife may think that their spouse is faking their situation, or they just can't fully grasp it. Like the husband may see a speck of dirt on the ground, but then say, you know what, I can't see the food on my plate. Can you put it on a different color plate? And they say, well, how did you see that speck on the ground? That doesn't make sense. So just giving them education that involves more understanding as to the specific diagnosis, and again, normalizing those types of scenarios, that it's not just your loved one. This is common across the board.
Okay, thank you, Melissa. And I do want to also point out that Kira Baldonado from Prevent Blindness just put a link in the chat to the Prevent Blindness caregivers, which I think is what Melissa was talking about. So I encourage people to check that out. Well, I want to thank all the panelists. It was really great information. I wish we had about 2 more hours to just talk with all of you, and everyone brings a different perspective, and it's such important information for people. But unfortunately, we have to stop this part of it now. We will have a Q&A again at the end. But what I'd like to do now is to introduce our last speaker on the forum for today, and that's Larry Woodard. Larry is a Prevent Blindness Aspect Patient Engagement Program graduate, and he's also a counselor at the Eye to Eye Peer Support Program at Lichter in New Jersey. Personal story around vision loss. Go ahead, Larry.
Yes, hi, everyone. Just to give you just a brief description of myself, I am an African-American male with gray hair, receding gray hair, gray goatee, and I'm wearing shades, dark shades, and I'm on a plaid gray and white shirt. I'd first like to thank Prevent Blindness for allowing me to share my story with you, and hopefully something that I will say someone will be able to recognize, and it will give meaning to someone, whether they are visually impaired or not. There have been a lot of great discussions about the intersection of mental health and vision loss. And I can attest that all of the things that's been said is true. And they're very meaningful, and also they're very personal to me. Because I think I've been through a lot of those things there. And just to share with you just a brief synopsis of my story, the journey for me started about 15 years ago, where I was diagnosed with glaucoma. I went to the optometrist, like many people do, to get a new set of glasses because it had been too long. And the optometrist told me that I needed to see an ophthalmologist as soon as possible. which I did. And when I saw my ophthalmologist, she verified that I had glaucoma and that my vision was very, very high. There, I tried various medications, too many to name. Some of them was in combination, some of them was solo. But for some reason, it could never really stabilize my pressure for a sustained period of time. And so after 5 years, I was referred to my ophthalmologist surgeon, who was a great blessing to me. And even with that, I thought my vision was fine because I could see as far as I thought, my determination that I could see. And I didn't realize though that my peripheral vision was closing in on me. But my central vision was there and I thought everything was okay. I mean, there were several times that things would go by, whereas I knew that they may be a problem, but I would counter that by saying something else. I'm making an excuse, like driving and passing a sign and saying that maybe I'm going too fast or something. Those are the types of things that I will make excuses for. And I was working, and I enjoyed what I was doing. I enjoyed many things that I was doing, such as traveling, social interaction with people. I love jazz music, and so I love going to live concerts and things. And so I didn't think anything was wrong. But I was scheduled to have my surgery, and about a week before my first surgery, there was almost 2 serious accidents that almost occurred. Fortunately, nothing happened to me, and nothing happened to anyone else. But there were 2 serious accidents that could have happened with me driving. And I had my surgery, and at that time, right before my surgery, I should say, that my vision loss had drastically changed too. And my vision loss came down when I had a little peephole of vision. And I was okay with that. You know, I gotten adjusted to that for that short period of time. And I had the surgery. And after the surgery, that peephole was clear. And within a week, I had an incident though. And what had happened was I had some change in my pocket. The change, I took it out of my pocket, it fell on the floor. And I did what you instinctively would do, which is to bend over and pick it up. But I was told right after surgery, don't bend, squat. But my instincts took the better half of me, and I bent over and picked it up. And when I did that, I felt like someone hit me in the face as hard as they could with a baseball bat. And I fell on the floor, balled up in a knot due to pain that I was receiving. I was there for about an hour waiting to the pain to subside and be able to find someone to take me to the emergency room. And I did so. And when I got there, they told me that the blood vessels in my eyes were so diseased that they were barely hanging on. And when I bent over, the gravitational pull caused them to drop off. So now that pinhole of vision that I had was white, and I became very light sensitive. Now you would think that my story there really was beginning with the vision loss, but actually it was really with the fear of. It was what I was going to do next because I was working, and now all of a sudden I'm not working. I didn't have a game A, B, or C in terms of what I was going to do. It was the fear of how other people were going to view me, how I viewed myself, my own self-identity, because my self-identity was tied up in my independence, my social interaction with people, my going to live events and sports, which I enjoyed doing, those types of things. And I was fortunate because I had someone, which was a social worker, talk me into going to the Career and Training Center in North Carolina, where I live, and which is rehabilitation services for the blind. And that was a key stand for us, key point for me, because while I was there, I learned a great deal of things. I learned about organizations. I learned about other things to get involved and to become a part of. I learned about technology, and I was not socially isolated because before then, I was going through a transition of things. I certainly was angry. I certainly was in denial about certain things. And I had a period of depression. But while I was there, being around others, that really helped. And one of the key moments there for me was that I had an opportunity to go to one of the football games in my state to see the Carolina Panthers, which I love going to. But now it was different monetarily. But my brother gave me a ticket to go. We went there, and I started not to go because my thinking was, what are people going to say about me? Are they going to say, why is he here? Because he can't see. But the better half of me got the best of me, and I decided to go. And when I went, it was a key turning factor for me, because what I found out is that people were not judging me like I was judging myself. The fear of my own judgment was overpowered. And I was told that it was an inspiration to people because they saw me as doing other things and not letting this disability take me down. And so that helped a great deal. And what I found is that becoming a part of is something very important. It happened the same way when I went to a basketball game for my the professional team in my state. And from that, I decided that I wanted to do something. I wanted to become a part of. And that's the key thing, I think, is to become a part of. I learned about various organizations such as the American Council for the Blind, the National Foundation for the Blind, the National Federation for the Blind, Fighting Blindness, and of course, Prevent Blindness, which is so, so important and been so helpful to me, because with that, I learned to advocate and self-advocate for myself and for others. And I think that's a key thing for people, is to learn to advocate, and that helps in becoming a part of your community, becoming a part of doing things, because you still have the same intellect, you still have the same abilities, but you may have to do them a little differently, but you still can become a part of. And in my conclusion, I would say that everyone wants to contribute in our society. Everyone wants to be able to give and leave a legacy of things good. And for me, it was being able to give back and being able to reinvent myself by going back to school and doing other things. So I would say, as Franklin Delano Roosevelt said in his 1933 inauguration, nothing to fear but fear itself. So don't fear, but become a part of. Thank you.
Thank you, Larry. That was really an important perspectives, and I think the motivation that you showed, that you described for staying involved and getting, I think, a very powerful message. What I'd like to do now is to invite all the presenters back. So the ones that were just on our roundtable, but also the presenters from the first part of the session. And what we can do now is to have about 10 minutes or so to answer some of the questions that viewers have sent in through the Q&A box. All right. So we're going to get through as many of these as we have time for. I'll just start right in. So again, this is for anybody who wants to answer this, or more than one person. The first question is, how do you best advise patients to keep on top of their diagnoses and best management plans? And in keeping with the theme, including for optimal mental health.
I can take that. I encourage patients to utilize resources like Foundation Fighting Blindness, the NEI, the online evidence-based resources that can provide updates in clinical treatments, clinical care. I also encourage my patients to prepare for their doctor's visits. It's really hard to remember all the questions that you think of over 3 months when you get into the chair and you have 5 minutes. So I encourage patients to like bring a list of questions to their provider to ensure that they get answered, and let the provider know, like when they sit in the chair, hey, I have some questions I'd like you to answer. I prepared them for you, just so that they know that they need to set aside the time to answer them.
Okay, thank you. Did anyone else want to add to that?
I'll add. I just think in addition to keeping up with the medical diagnosis, it's important to keep up with the patient's rehabilitation process. So a lot of times the client may be dealing with anxiety that they're not able to do a task. And then in conversation, we'll find out that maybe there's a tool such as a screen reader or a magnification device, or maybe the client hasn't had any training with a white cane. And so just as a mental health provider, encouraging them to continue on and finding those vision rehabilitation resources that can help them navigate as their vision either remains stable or changes over time.
Okay, thank you. Now,
And I would just like to add to, oh, sorry. I'd like to add to, like, I think it's good for you for us to like express our goals to our providers also. For me, that could have been like, I want to be able to decrease pain, increase my activities, and go back to work. Because them knowing your goals can help when you're advocating for new treatments, for new devices and medications, just to have that list going.
Yeah, definitely, you know, taking an active role with providers, which is something a lot of people don't feel comfortable doing, especially older people, I think, who are more acculturated to think doctors are the experts, they know everything, and you're just supposed to sit there and listen. So thank you, that's a good point. Now, something that's come up, been mentioned a couple of times earlier, was healthcare navigators. Can somebody say or define what a healthcare navigator is? And also say what the impact of that might be for increasing the use of healthcare navigators, especially in rural areas?
I would say that a healthcare navigator could be thought of as sort of a liaison between the patients and providers. Right now, we've kind of touched on that we have a fragmented system where referrals are difficult because that network may not be in place. So, especially in a rural setting, if an ophthalmologist were able to connect a patient with a patient navigator, that person could kind of take on the role of coordinating care, finding a mental health professional, finding someone to provide orientation and mobility services, the low vision optometrist, all of the different components that make up a person's rehabilitation process, and also provide support and empathy, and maybe also plugging that patient into different sources of community like support groups, and maybe helping them brainstorm about different goals, like was mentioned before, that they have that they would like to be working on.
Okay, yeah, thank you.
And I will add to that. I think sometimes healthcare navigators might not have vision loss themselves. So, there's patient navigators and there's healthcare navigators, and both are out there, and there's models of this, but we, and I think in this, with those who have vision loss and blindness, they could be helped by both potentially, especially in the rural areas, someone to help potentially with transportation. So in some models of care, a healthcare navigator is someone, that is able to drive, sighted individual who could pick up this individual and take them to their appointment, for instance. And so, that's a model that, could be helpful in some cases. But then a patient navigator is somebody with that lived experience, to my understanding, or often is that someone who understands, has that vision loss themselves. And when it came up in conversation during the task force, Many people mentioned how important it would be to, right after receiving a diagnosis, to have a patient navigator in the office so that they're not walking out the door feeling super scared and alone and uncertain about their future, that there's somebody there to just say, to sit with them, and to be available to say, I understand, even if I don't have the same condition as you. And so I think both models could be very helpful for this population.
Thanks, Julie. Okay, we may have time for just one or two more questions. So this question came in earlier in the session, and I think it was in response to Dr. Varadaraj's presentation. And the question that was asked is that your slide notes that partnering with schools of optometry and ophthalmology might be helpful to help people understand, I guess, the mental health implications of vision loss. And I guess I wanted to throw out to everyone else as well, as I'm trained as a clinical psychologist, I know the American Psychological Association has a division of what they call rehabilitation psychology. But the fact is, in training for clinical psychology, I never saw anybody with anything like hearing loss, vision loss, anything like that. So how early should we start letting people know about essentially what comprehensive care involves and that is needed, and stop having it so completely isolated from every other discipline?
Thank you. I don't believe I mentioned that, so the question must have been for whoever spoke after me, but I can take a stab at answering it really quick. I think the overall idea is to start early and have a very comprehensive model of care delivery. So in terms of, for example, connecting potential patients to low vision rehab services when they come into the clinic can start as soon as the primary care level, when you're testing someone for their vision loss and you identify that they have an eye condition and they're having functional difficulties that could benefit from low vision rehab. And at Hopkins, at WOMA, we've advocated for when, talking about clinical terms, when there's a visual acuity of say 20/40, which is you're reading a few lines less optimally than you could be, referring patients to low vision rehab services that can help them navigate everyday life.
Okay, thank you.
I will also just add real quick that I completely agree to the idea of starting in med school and really providing this training. There is no harm and no possible downside to providing this education even earlier than residency, from my perspective.
Okay, thank you. Well, believe it or not, we are just about out of time. This is the fastest 2 hours I've ever experienced, I think. So first, I want to thank the panelists for the individual presentations, for the panelists and group discussions. Really informative. It's great information. I'm so glad this was recorded. So many people watch this today, but many more hopefully will watch it after today. I also want to thank everybody who participated, who asked questions, who watched and listened, and hope this information is useful for the work you do.